Good morning and welcome to our second broadcast of the EIT Health Summit. EIT Health is a network of best-in-class healthcare innovators backed by the EU. They deliver solutions to allow European citizens to live longer, healthier lives. And this summit is a wonderful opportunity for you to interact with the latest thinking and developments in healthcare. This year, we've put together a lovely program for you, which will be a mix of presentations and discussions, and of course, a range of networking opportunities. In the last session, last Tuesday, we talked about artificial intelligence. And you can rewatch this episode if you go to the website or simply share it with colleagues or others you think that would be interesting for. Today, we're going to switch our focus to high-value care. Next Tuesday, we will be focusing on new business models and look at how they help meet consumer details in an ever-changing landscape. And then, next Thursday, December 3rd, is the final of our EIT Health Catapult series and our award ceremony. Now, we'll switch to Jan-Philippe Beck. Jan-Philippe is CEO of EIT Health, and his objective is to support EIT Health's vision of connecting the healthcare needs of European citizens with policymakers and a wonderful network of 150 partners. He aims to deliver innovative healthcare solutions that can positively transform the outcomes for people across Europe. Here is Jan-Philippe Beck.
Good afternoon. I'm Jan-Philippe, the CEO of EIT Health, and on behalf of the full EIT Health community, I welcome you all to our session on high-value care on the 2020 online EIT Health Summit series. So the EIT Health Summit is our flagship annual event. The EIT Health Summit brings the worlds of business, research, education, and healthcare together. As I already said during my opening of the event, with the summit, we want to give you all a platform to discuss some of the most critical and relevant topics in healthcare innovation to help improve lives across Europe. We want to give the stage to different perspectives, and this is so important in health and healthcare. As COVID-19 is painfully showing to us again, population health is the very backbone of our society, of social cohesion, and also economic prosperity. So I would like to share with you why high-value care is so important for EIT Health, how we understand it, and what we do in this area. So Europe's healthcare systems are unsustainable today. The cost of delivering healthcare is rising faster than GDP. We have more patients requiring care, due in large part to increased life expectancy, our aging population, and the rising prevalence of chronic diseases. These issues are quite well known and also understood. Now, alongside this, evidence now suggests that not all healthcare spending is contributing to better outcomes for patients. In fact, it's estimated that around 30% of resources are spent on avoidable complications, unnecessary treatments, or simply administrative inefficiencies. So we must address this, as more treatment cannot and should not be the goal of healthcare. Better health is the ultimate goal. For this to occur, things need to change. We need to measure the right outcomes and incentivize payers to pay for outcomes rather than for products or services, as is traditionally still often the case. Only when a patient's health is improved can we define this as a valuable delivery of healthcare. So high-value care is a concept that aims to address this by refocusing healthcare, and we must support the evolution of healthcare services towards this new model. So our high-value care forum will be the center point of high-value care in Europe and aims to support this transformation, creating lasting impact for patients. The forum will bring key stakeholders together and encompass education and training, database solutions to assess and compare outcomes, and best practice sharing so that we can learn from each other. There will be a case study library featuring success stories from pioneers across a diverse range of healthcare providers that will demonstrate real-world evidence on-the-ground implementation of high-value care. And we want these examples to inspire people to take action by showing that not only is high-value care feasible, but that it can also be replicated. So, of course, we will also populate the library with cases from our own project portfolio that we develop and grow. So for us at EIT Health, advancing high-value care relates to our strategy to deliver societal impact. EIT Health aims to deliver societal impact understood as the implementation of widespread socioeconomic improvements to society. So we believe that societal impact is constructed from the connection between innovation and society. So for this, the engagement of citizens and patients is highly relevant. It's measured against what really matters to people. And here, high-value care plays a key role. And finally, societal impact is assessed on principles of integrity and fairness. So ethics and legal principles matter. So the forum is chaired by Christina Ackermann. She's currently an affiliate faculty at the Dell Medical School at the University of Texas in Austin. She will also be running this session. And the session will be split in 3 parts. First, outcomes, benchmarking, learning communities, and scalability. Second, on incentives and rewards. And thirdly, on cultural change. We have fantastic experts joining us for these topics. I'm grateful that they are here with us today. And Christina will introduce you to them shortly. And of course, you are all invited to contribute to the discussion digitally and online. Enjoy the session on high-value care at the EIT Health Summit. Thank you very much.
Thank you, Jan-Philippe. We're going to focus on the topic of today's summit, high-value care. We have convened a panel of experts for you to explore patient outcomes, how we can measure their impact, and also why incentives are key to successful adoption of high-value care. Please contribute to our community conversation, engage with our content, and interact with your peers via the chat function. Your comments will be visible to everyone, so please be polite and courteous to each other. You can also ask our speakers a specific question or simply vote for the question that you like best that have already been asked by others. Throughout our conversation today, we will be using multiple choice polling, and we'd love to hear your personal views and opinions by filling out those for us. And externally, please share your views, your opinion, and your experiences using the hashtag EITHSummit. Now, if you would like to use your phone or your tablet by filling out the polls, simply scan the QR code that you see on the screen right now, or you can also find this on the webpage of the event. Here's Christina Ackermann, our chair for today, joining us from Sweden. She is affiliate faculty at the Dell Medical School, chair of the EIT Health Advisory Board, and on the steering committee on the Coalition for Health, Ethics and Society at the European Policy Center. She's going to set the scene for us on evidence-based transformation in patient care. Christina, thank you for joining us today. It's lovely to see you. How are you?
I'm very well, thank you, Anne-Marie, and thank you also for your very kind introduction. And greetings from, I would say, a rainy Sweden, where we are truly looking forward to lighting the first candle in the Advent candlestick this weekend to get some light into our houses here. As we heard in the introduction from Jan-Philippe, a substantial amount of health spending could be channeled towards better use. The numbers show that many patients are unnecessarily harmed at the point of care or receive care that makes no difference to their health outcomes. These issues of highly variable outcomes, harm that could have been prevented, inappropriate care and unnecessary spending, occur worldwide. The problems in healthcare delivery have deep common root causes in the failure to measure health outcomes. We do not truly know what matters most to patients, and we are not able to compare these outcomes easily between organizations to share best practices and learn from each other. So improvement potential is huge. We need to take the waste out of the system and make the care high-value care. We do not need more care, but better health. So with us today are 3 distinguished leaders who have, with their organizations, made substantial progress towards high-value care. Together, they will cover 3 important steps on the journey, starting with the health outcomes that matter most to patients at the center, and then move to discuss reward systems, incentivizing health outcomes. Finally, we will discuss how a focus on outcomes influences the culture. Because to be able to deliver the health outcomes that matter most to patients, new ways of working together in a more integrated and solutions-oriented manner will be needed. What is holding us back? Let's have a look at our first poll today and have your opinion on the challenges to transform to high-value care. Please start voting now. Is it about the health outcomes or defining the health outcomes, or informatics, interoperability, or the second part, the reward systems, or the third part, the culture? Because in the first place, when we talk about health outcomes, or maybe it's about the informatics interoperability needed for bigger scale comparison of outcomes that holds us back. Defining the health outcomes or the informatics interoperability. Or when moving to the reward systems, is it about establishing payment models that truly incentivize the outcomes that matter most to patients? Or, as we discussed, the third part, the culture, and the commitment by leadership to get the internal resources needed and make the necessary investments for long-term transformation. So please let us know what you find the biggest challenge to move to high-value care. And I believe we have some results, Anne-Marie. Is that correct?
We do, yes. The first results, they are coming in. And actually, it's nice to mention that payment models definitely were the favorite at first. But now it's been taken over by the interoperable data platforms. So about 41% is voting for that option. The data platforms are most favorite at this moment, Christina.
That's not a surprise, Anne-Marie, is it? Because we know that there is a lot of work going on about defining the health outcomes and starting to implement them. But once you start implement them and you start to get to know your own results, you also would like to start comparing them and benchmarking outside your own organizations and putting learning communities together. And that's unfortunately still today a challenge, although there is work ongoing in this direction. And I am now believe that this is very important piece to be covered in our first part, and very interesting to hear our speakers also reflecting on this later on in the program. So let me start with introducing our first speaker on stage, and I am delighted to introduce to you Peter DeBay, Managing Director at Santion, and I would like to start with congratulating you, Peter, on recently being awarded the 2020 Value-Based Healthcare Prize. At Santion, you have developed a scalable model in the Netherlands, which where doctors and care delivery teams from 7 hospitals measure and compare patient outcomes and associated costs to learn and improve their care at their hospitals and to better inform and empower individual patients. So I think the poll leaves open floor to you, Peter. Very welcome, and we are looking forward to learning more.
Thank you very much for having me, Christina. Let me start by giving you a brief introduction to Santion and to our approach to value-based healthcare, or to high-value care. So Santion is a network of 7 acute care hospitals with a national coverage in the Netherlands. We are the largest provider of hospital services across the country. And we defined a couple of years ago a number of ambitions that we aim to achieve together. The first one, and I think it's a really important one, is that patients are actively involved in their treatment choices. The second one is that our professionals work closely together across the 7 hospitals that are part of our team. The third one is that we share forces in innovation and research. And then we have a key focus on measuring quality, measuring patient outcomes that matter to patients, and make them transparent, publish them, and learn from them. And then the fifth one is about the affordability and the accessibility of our care. We feel a responsibility to continuously work on that. And combined, these ambitions are basically our guiding principle. Value-based healthcare is our guiding principle, with a focus on continuous learning and improvement. We define patient value as health outcomes divided by costs. And our approach to improving patient value is by running continuous improvement cycles. We also go for value-driven research and innovation. We aim to train our professionals in a way that they have a focus on value, and these are our doctors, but also our nurses, really important. We work on value-based contracting and value-based procurement with suppliers. Let's talk a little bit more about the improvement cycle. So basically what we do is that we run an improvement cycle within each of our 7 hospitals and across the 7 hospitals. What we do is we collect data, we look for variation, we analyze the variation, identify improvement opportunities, and then try to implement those improvements. Very, very straightforward. But the way that we do it is that we run 2 improvement cycles per year, so every 6 months. We do this around a patient group and not around a medical procedure, which I think is really at the heart of the approach. And we aim for full transparency on patient outcomes, costs, and processes. And we currently do this now for 15 patient groups. We use standardized scorecards with those outcomes, costs, and processes across the hospitals, and are very patient-centered in this approach. We do this now, as I said, for 15 different patient groups, and our latest addition is COVID-19. So this summer we started with over 30 medical professionals to work on an improvement cycle for our COVID-19 patients. And we have already learned a lot from this approach. In essence, it gives us a holistic view at the different treatment options and how they compare in terms of outcomes and costs, and are able to decide together with our patients what is best for them, given their preferences. So what are our ambitions? This is my last slide. What we see is that our improvement teams go through different phases. The first one we call internal transparency. This is where we create a trusted environment for them to have an open discussion. We work on getting to reliable data, which isn't always easy, and we already saw this in the poll earlier, that this is an important topic of focus for a lot of people. And we implement some obvious improvement opportunities. Then we get to a phase that's called external transparency. Here we make the results available to everyone. We deepen the analysis and we start working on shared decision making. Which outcomes are relevant to our patients to discuss between a doctor and a patient. And then we move to a standard of care. We try to define what do we really consider high value care. Continuous improvement, innovation research, and also value-based contracting. Some lessons learned: we create a safe environment to learn from each other, don't judge each other. The medical professionals are in the lead. We take a data-driven decision-making, and it takes time to learn that. And finally, and it's really important, is that patient participation is key. And therefore, we ask one of our patients to give you a message about what that means for him. So here's Jan with a video.
My name is Jan Sinema, and I was asked to join the platform of improvement, the treating of diabetes in the OLVG. I was asked, I think, because I have diabetes for a long time, already since 1974. I think the most important reason to join is that for the first time in 46 years, I was asked what I think about the treatment and the whole process around it from the patient's point of view. It sounds maybe a little bit strange, but they never talk to me, they always talk about me. So this was the first time that I was really involved in the whole process, which I really liked. The view from the patients is rather important in that, because, well, we are the players. We are the ones who they're talking about. And well, we have the experience over the years. How do they look at us? What do they tell us? And what's my role in that? Not really heard. But now, for the first time, I'm joining a group who wants to improve the whole process of treatment. And of course, my my experience in that, I think that is very important, because what do I want? What do I like? What does have some improvement for me for the next years, for the many years to come? I think this whole process of innovation is not just because it's nice to innovate, but it's about added value for the organization, added value for everyone who is a participant in that, and added value, of course, for us as a patient.
Thank you for sharing your impressive work, Peter. And also thank you to Jan for joining us through video. Before we hear from the audience, let me start with asking you for a reflection. You talked about establishing transparency in 3 steps. First internally, then externally, and finally to a standard of care and shared decision-making. I believe you have a model called the co-lead and lead model, where different hospitals take lead and co-lead together. And could you please describe maybe this a bit in more detail, and also reflect on the advantages you see with this to be able to establish the trust I expect is needed for making transparency possible?
Of course. Thank you. That's a great question, Christina. So let me start by I think bringing forward that the fact that we are a network of 7 hospitals, I think really works to our advantage. And I would recommend to others to also take a similar approach, because what that does is that it creates the opportunity to compare across the 7 hospitals and really learn from each other. And I think that's really at the heart of our approach. But it also means, obviously, that it adds some complexity, right? Because we are with 7 hospitals with many physicians and nurses involved. We need some way to really structure the process. And the way that we did that is by for every one of those 50 medical conditions, there's one hospital that's in the lead and there's another hospital that's the co-lead, and together they prepare the work. Together they look at the data across the 7 hospitals. There's a project leader involved and a data analyst involved, and they prepare the meetings, etc. And by taking this approach, not everyone has to take the same effort, and together we can actually really get to meaningful insights for all of those 15 conditions. So I think it's just a very sort of straightforward, simple way of organizing the work, and it works really well because people are proud to be also the lead in a co-lead hospital, and they can get on stage and share the results, but also work together in a team across the 7 hospitals. I think the second part of your question, Christina, was more about creating a learning culture, right, and have like a safe environment. And I think this is really also a key element of the approach. One needs reliable data, right? And to be honest, initially, for every new patient group that we start with, there is no such thing as reliable data. We always start with data that is, that is not high quality enough. Some call it even bullshit data. There's always troubles with the data. So we need time to get to correct data, to share it with the professionals, to see where we went wrong. But after a couple of these cycles, after 2 or 3 cycles, we get to reliable data. And this is the time that we call internal transparency. The data is not fit yet to share with others, but it is already very interesting to look into and to get more knowledge about one's own results and also each other's results. But in that same period of time, the first year and a half basically for a new improvement cycle, this is also the time where the professionals get to know each other, really get to build trust and relationship amongst them, and start to be open to share their insights.
Thank you so much, Peter. And I'm thinking about this and the poll we did in the beginning here, where we have informatics interoperability as the number 1 challenge voted by the audience. And you obviously are sharing a lot of data across different hospitals, but within the same group. So I'm interested to hear from Anne-Marie. Do we have any questions, Anne-Marie, from the audience on informatics interoperability to Peter? Otherwise, I have, of course, one, but I believe there are many out there. So Anne-Marie, would you help us on this?
Yes, absolutely. I have been monitoring the questions that have been coming in. I have one here. Let me repeat it for you. How do you define value in the different categories listed? This term seems to have a different meaning for different sectors.
Yeah, so the way that we define, whenever we start a new patient group, our professionals come together with patients. This is very much involving patients in that process to define a standardized scorecard. And on the scorecard, there's always the same things. There's outcomes, so the quality from a patient perspective. There's cost indicators, and there's a number of process indicators that are typically about, the number of days something takes, for example. But especially the outcomes and the costs are really important. These matter to every patient. These matter. We have to define them for each patient group, but they're not the same. For each different patient group, there's different outcomes that are relevant. Right. And also for each patient, the one outcome may be much more relevant than the other. So the weighing in the end needs to be done by the patient. And we also always use the ICHOM standard sets that are developed by ICHOM to get to a first set of outcomes that we then try to measure.
Okay, so that is your starting point for this.
Absolutely, yeah.
Okay. Let's see, I have another one here. How have you used technology to make the working together easier amongst the network of 7 hospitals? What challenges did you face, and how did you solve these?
That's a great question, and to be honest, when I saw the results of the poll, I actually would not really agree, sort of, from my perspective.
Yeah.
So the way that we started, and we started really the approach that we take now with these improvement cycles, we started early 2016, so this is about 4.5 years ago. We didn't invest in technology at all. This is really about getting the data from the existing systems. I mean, all our hospitals have EMRs, but they don't have the same EMRs, electronic medical records. They have different EMRs. And what we basically did was we put data managers, data analysts in charge, have them collect the data, work with their professionals to get to meaningful data, and then start benchmarking and comparing. And everybody can do this. You don't need any sophisticated IT or technology to be able to do this. Now we've scaled up to these 15 conditions, and we have ambitious plans to grow it even further. We do need more technology to underlie the process. But initially, to get started, I really don't think you need much at all.
Okay, so you basically can start tomorrow if you'd like to.
Yes,
well,
definitely.
That's an uplifting message.
Yeah.
Let's take a look at one other question. What would you say is the role of digital health or even remote patient monitoring solutions in the collection of outcomes data? Is it important, and why?
Yeah, I think is your question about PROMs, the patient-reported outcomes?
Well, the role of digital health or even remote patient monitoring solutions when you're collecting data.
Yeah, I think it's becoming more and more important. So it is true that, and I think it also reflects a little bit on your previous question, it is true that we very much still focus a lot of our effort on what is happening within the hospital part of the whole patient journey. And what we try to do more and more is to be able to collect data across the entire patient pathway. And in order to do so, we definitely need to make use of all kinds of new e-health solutions that, along the entire care pathway. But there's already a lot of work to be done within the hospital, but we're now moving into the entire pathway. Yeah.
Okay, and then one final question to round up maybe. So as the Santiago hospitals, you have a good understanding of how well you're reaching the outcomes of healthcare that are most important to the patients. What does that knowledge do, or how does it in fact impact the processes in the hospitals that you're working with?
Yeah, so I think what it mostly does is that it is really motivating to our professionals. This is really what is the reason why they started doing this job in the first place. And I think that is why I am such a big believer in this approach, value-based healthcare, high-value care, because it really brings back, for the professional, why they are doing this job every day. It gives them insights into the outcomes that matter most to their patients. And what it does is that it gives them the opportunity to work on improvement by themselves. So it empowers them. It empowers the professionals, it empowers the patients as well. And I think this is at the heart of why this is such a good approach. And then the processes they follow. So that's the next step, but it starts with gaining insights in the outcomes that matter most to patients.
Good advice, I guess, as well for our viewers. I think we have time for one more and the final question. How to implement the transparency culture among professionals and turn it into a positive thing to avoid resistance, that they don't feel questioned?
Yeah, so couple of things to say about that. What I notice is that it's actually not very hard at all. As I said earlier, measuring outcomes, gaining insight in those outcomes that matter to your own patients is really motivating.
Right.
So there's not necessarily resistance, which I see in practice. However, obviously, it is an additional effort. It takes time to do this. So whenever we start a new patient group, we start with where are the motivated professionals? Who is taking to take the lead? Medical professionals need to be in the lead. So we don't start in an area where there's no enthusiasm. We always start in an area where there is, and what we see over time is that once there's one group started, there's a different one standing up, and there's another one. So you need to kind of build over time.
It's contagious, you could say.
Absolutely, it's definitely contagious. Yeah.
Wonderful. And with that, I would like to hand it back to you, Christina.
Thank you, Anne-Marie. And it's very reassuring to hear from you, Peter, about the patient value you put at the center, talking about what does value mean, that it all starts with the patient value, because it's inherently less costly for society to have its citizens living in good health than in bad health. So starting with patient value, as you do, is a starting point for defining value. And also reassuring to hear, I believe, that you feel that start collecting data is possible, as you have shown between 7 hospitals, and that data informatics interoperability hasn't been the biggest challenge for you. But I can also imagine that we will have a discussion later on, maybe when we see the poll again, and see what happens when you are moving into bigger scale comparisons on an international level. And are we ready for that yet? So a warm thank you to Peter. And you will be back with us in the third panel when we would talk about the culture in more detail. But now we are moving into part 2 and the reward systems. The external and the internal reward systems needed to incentivize the health outcomes to be at the center of everything we do. And I am honored to welcome Dr. Henk Visse, founder and medical director at Diabetes. Patients with type 1 diabetes in the Netherlands are treated according to international standards. But however, looking at the performance of individual clinics, patient outcomes vary greatly. And in the Netherlands, Diabetes has been a pioneer in value-based diabetes care, offering a novel care model focused on the patient's e-health solutions and the unique patient experience. And Diabetes also moved out of the hospital and it created its own center to really be able to focus on this unique experience. Most welcome, and please tell us, Dr. Visse, about your journey.
Yeah, thank you so much, Christina, and welcome to you all. Diabetes was founded in 2006. We moved out of the hospital, obtaining our own healthcare license to get payment back from the insurance companies if you have the contract available. You can see the picture in the environment really shows you a welcoming environment, which we were able to establish, roundtables for consultations, which I was not allowed to have in my clinic, in my previous clinic. And Diabetes, the most important part of Diabetes, to have an integrated practice unit. That is the team with all the different disciplines living together in one place. And in the current hospitals, they live in different managerial silos. So it's much more difficult to align all this, certainly at the time when we stepped out of the hospital. With a focused team, it's just like with the Olympics. If you focus, you get better. And if you get better, you get smarter, also more efficient. So our current staff, with all the help of the technology, can treat twice the amount of patients as the average in the Netherlands or across Europe. And if you treat twice the amount of patients with the more efficiency and the help of IT, you get also twice the patient load and the experience, and that also makes you better. Everything turns around IT. We share a lot of data with the patient. So if you do an upload of your device, in 5 minutes back, you have your results in your iPhone in a safe environment, and you can watch how you progress with your daily measurements in blood sugar data and how to improve with your insulin dosing. We get it also on our dashboards. And if we see deviations unexpected, we can coach and not wait until you have your next consultation in 2 to 3 months' time. So we do a lot of it remote. And gradually we get better in the Netherlands. We have now 5 locations across the Netherlands. We are the biggest type 1 center across Europe, and we are currently expanding more abroad. Since we are our own entity, we also have all the financials. We have to pay for all the costs on IT, on real estate, on staffing costs, on materials. So we exactly know what the costs are per patient, or different type of patients or age groups. And that together with outcome, you have the value-based healthcare construction. And with all this knowledge, we can try to predict future outcome. If we go to more devices, more intelligence, closed loop systems, how much we can reduce in the future on complication costs. So it is worthwhile for insurance companies to invest in us and to build a long-term contract now for 10 years, ceiling-free, so no budget limits, where we can really do our best to get to a level where we reach a normal life expectancy and a life without complications for the type 1 patients. Thank you.
Thank you so much, Henk. And this is very exciting to hear from you about this. As we saw, I think Anne-Marie showed us in the first poll that payment models is also a challenge that came quite high up in the ranking. And you have step by step progressed to a 10-year contract rewarding health outcomes achieved, as you described. And then my question to you would be, how do you monitor transparency to make sure that you avoid selection bias of the patients you treat, leaving the more difficult patients to other clinics?
Yeah, it's a great question, and that's also what our competitors bring forward, that we pick the best patients out of the Netherlands. And actually, when we look at our natural catchment areas, where all the clinics have refrained in the nearby area for taking care of type 1 patients, and you select those patient groups from your own database, you can see the influx and outflux, and you really can see that the normal catchment area, we have the best performance, even better than those patients coming in from elsewhere. And if the patients coming from elsewhere are their best patients, as they claim, then the results, as you have shown on the picture, you see there is a wide variety in outcome, and we should focus more nationally and internationally to create more value for patients by comparing and be open and transparent on data.
Thank you very much for clarifying this, and we will certainly continue the discussion. But I would now like to also invite Dr. Jan Hasselset, Professor in Healthcare Quality and Outcomes at Erasmus Medical Center, to join us. Erasmus is a large university clinic in the Netherlands, for many years setting the international incentives towards fostering a culture for health outcomes, all the way from the consultation room to the architecture of the buildings, to bringing together national and being part of, and also being instrumental in European benchmarks and learning communities. And Jan, you have been in the center for this work over many years now. So it's a pleasure welcoming you, and I'm looking forward with the audience to learning more about your work.
Thank you, Christina. It's also a pleasure to be here. Thank you for the invitation. The Erasmus University Medical Center is located in the city heart of Rotterdam, and together with 15,000 employees, we treat multiple complex patients. And recently we moved, as you said, to a new building, and especially the clinic is built with the attitude of healing environment. And we also tried with our architecture to stress the more disease team orientation than the originally and classical discipline orientation. About 5-6 years ago, we started with the concept of value-based healthcare. And we started with a group of pilot disease teams. now ambassadors. And those pilot disease teams were selected on the basis of their enthusiasm. And they are quite diverse in their diseases. And with these disease teams, we learned a lot about the implementation. So these 7 disease teams gave us experience. And with this experience, we designed a kind of a blueprint. And with this blueprint, we help the other disease teams, about 20 now, so about 30 in total, throughout their journey towards value-based healthcare. So a multitude of sessions dedicated to a certain topic to start with designing their outcome set, consisting of clinical and patient-reported outcome, together with patients and together with surveys among patients, to finally come to an implemented outcome set, measuring it and using it for implementation. And finally using it for improvement, because that is the most important goal of value-based healthcare, a continuous improvement cycle, as you can see here. So we started with the formation of a disease team, analysis of the current care path, and then the design of an outcome set. Outcome set will be measured, and the results of those measurements are used for individual improvement. And the individual improvement will lead to, in aggregated form, to an improvement of the process itself, and then finally to the financing. And the ultimate goal is to have the completely integrated care, the full cycle of care. This is the most complicated form, especially for a university hospital to work on. That means that we started with the ambassadors, with the innovators, and finally with the early adopters. And this is what we have done now for about 30 disease teams. But the most important thing is now coming, and the most complex, is the silent majority. And that's a different kind of implementation, with a different approach and more complex to work on. Next to our regional work, local, regional and national work, we also try to work in an international basis. And our very interesting partners are in these 8 other university hospitals throughout Europe. And we call ourselves the European University Hospital Alliance. And with this alliance, we have achieved to apply for a number of European projects, among which is in the EIT Health, to work together on this concept. So we are very active, but there's still a lot of work in progress. Thank you.
Thank you so much, Jan. And it's very exciting to have both of you on stage together with the experience from Henk and Dieter, having everything in one condition under one roof, and then contrasting that to the university clinic that you described, Jan, with very many challenges, of course, in making these integrated practice units and the full cycle of care. And we heard from Henk about the external payment model being established in a 10-year contract. We also talk about reward systems and incentives from the perspective of internal incentives. And I would love to hear from you what you see as the strongest internal incentives that you have noticed in this largely complex world you work to make difficult change happen.
Well, I deliberately shown you the build-up of our implementation. So starting with a group of very enthusiastic people, they are the pioneers, they want to do this despite the fact that it's not perfect. So they are our ambassadors, and with the ambassadors you can create a flow, but it means that you need to also have an expert team, a support team in the hospital, a central support team helping them. Then at a certain moment you had a group of people who need more support from an IT information department, IT department. And then later on you need also facilities. So it is a building up of a complete change, complete movement in the hospital. And finally, and certainly not last, is the fact that you need to have support from the board of executives. And this joint effort makes the enthusiasm, makes the culture change into a certain direction.
Will that take you, do you foresee, all the way to the right in the curve that you showed about you are on the left side now moving into the majority of the group? Will this be, is this your formula for success?
Yeah, I think so, absolutely, yeah. And now, as I said in my introduction, the silent majority needs a different kind of attention. There it needs to be perfect. Because otherwise they say, well, it doesn't work. So you need to be perfect then. While in the beginning you are able to make mistakes or to have systems which doesn't work properly, because those are the pioneers.
Yeah, great, thank you, and very encouraging to hear that you have come so far in this and moved along the lines here. So I think we are now moving into hearing from the audience and the questions, as reward systems come up as a challenge in the first poll. I believe you have plenty of questions, Anne-Marie, coming in. Am I right?
Yeah, you absolutely are. You are right. Let's just get in with the first one here. On your contract payment models, do you include risk-sharing agreements? Whoever feels called, I see you nodding.
Yes, we do.
Dr. Faison.
We take the risk of reaching outcome, and otherwise we have to pay back if we don't reach target. And if we reach target, then there is a comparison in price with all the other competitors in the Netherlands, and we get a profit share of the difference.
All right.
So that's one way of doing it. And another possible profit share is how do we perform and what is the projection on the long term. So we get a little profit share of the possible projected reducing in cost, future cost on dialysis, amputations, etc.
Oh, that's interesting. Is something similar going on for you?
Yeah. We have not that much experience in these kind of contracts. We have one which is quite complicated. It's on integrated care together with 3 partners outside of the hospital. One contract and one bundled payment. That's very, very special to do and very challenging to do. But we also work with one insurance company with shared savings and shared losses.
Okay, yeah. So there's some more interest. Oh, if you want to add something, go ahead.
It's very important to have a long-standing relationship with insurance companies. And people tend to change over time, but it's very important that also in the insurance company there are people focused on this kind of contracting issues that will help. And Silver Cross was great. And now you see that other insurance companies also are open to build this long-term contracts. So you have to start from somewhere.
So, and how do you build and maintain those relationships?
By transparency.
Right.
I try to be transparent on, let's say, what I earn to what it costs and how we do the payments in salaries, especially that is a sensitivity. And if you can come across that and display the real cost of healthcare and what you need to further improve, then over time you build really a level of trust.
So sharing the information is on the basis on this. Okay, wonderful. Now, to stay at the financial aspect a little bit, another question that we've gotten is, how do your investors know you're providing value to patients? What is the value the health insurers believe you offer them?
That is a great question. I also asked that to the insurance companies. I come in for the next year and they say, we think about a little cost reduction for next year. I said, well, my first question is, were you satisfied with our care delivery over the last year? And they had no idea. And so I had to display first our outcome parameters. And they say, actually, we can do something more, but then we need to increase the price a little bit rather than to reduce it.
Do you recognize this?
Yeah, it took some time for the preparation of our contract because of the natural feeling of we against them. That's changed over time. And we ended with about 3 indicators which were quite diverse, were different. One is more medical, one is quality of life, and one is more patient experience. So that was the final result. And to give you an idea about how broad the outcomes can be.
Yes, please. Yep. Okay, wonderful. Moving on to the third question that we have here. Have you tried implementing your remote technology for diabetes in Germany? Could it be that it's easier to deal with GDPR issues in the Netherlands than it is in Germany? Do you have any idea about this?
The Netherlands is really on the front row of delivering new kind of arrangements, also with remote care and telecare. There are, if you see any objection and any problem, you can try to solve it, and the whole crowd is very keen to help you. In Germany, they introduced recently the DIGA system, where you can get reimbursement for remote care. We are looking into that since we are expanding abroad. but also in other countries where we work, the more south you go, the more easy it is, because the more difference you can make, the more value you can create, the more easy it is to get alignment with care providers and payers.
So it might be possible that you're expanding in the future.
We do currently, yeah. We have
Wonderful.
our first clinics abroad, and that is really growing fast.
So we'll take a look at that and keep that in our minds. Now to focus on something that's going on right now, and also why we have to distance on stage. Of course, we're in a COVID-19 pandemic at the moment, and from what I understand, that Diabetes was able to switch to 80% virtual right at the outset of the escalation a few months ago.
Yeah.
Are you planning to stay virtual even after we return to normal?
We were already prepared on remote care, as we do, with the continuous every day be available for patients and looking at our data. So we could switch it in March in 3 days' time, have 80% of consultations from home, where the care providers were sitting at home with screen-to-screen contacts, with scheduled visits with patients. Currently, this is continuing. We had in the summertime that patients went back for physical consultations. You need to take blood samples, etc. And then in the second course of the disease, we could switch down again. We will remain after COVID, this, to some extent.
Okay.
I think it will be more closer to 50% rather than to 80%. You need the physicals, also for motivation, but also for physical exam, blood samples, etc. But it is there to stay.
Okay, that's wonderful.
And patients highly appreciate that. They wonder, if you do only a consultation with communication, why should I have come? We could have done that on screen as well. And that is obvious a good argument.
We have the same experience. Yeah.
The same for the Erasmus Hospital. Yeah. So you'll be remaining or staying virtual for at least a percentage of what you're doing. Yeah. And good results so far.
Yeah, that depends on what the activity is, but certainly when you just have a conversation and the patient is agreeing with it, because you need to check.
Of course, yes.
Needs to feel comfortable with that kind of communication. And if so, then you can switch easily. Yeah.
That makes sense. Yeah.
You need to build in your checks, because if the patient does come physical, you have your check. But if the patient doesn't show up and is remote, you must have some kind of checks on a possible lost in follow-up, performance of uploading data or missing data, etc. So you must be very keen not losing gradually your patients in the dark.
A good experience so far, but also much more to learn. Let's switch to our virtual connection today. Christina, I'll hand it back to you.
Thank you so much, Anne-Marie. And listening to this, I think this is exciting to see, as often discussed now, about how quickly we can do things under their current situation that would not have been done or would have taken many years before. But isn't there also a risk when we try to do everything and make everything digital? So my question to you would be, how do you avoid, when moving into virtual, where there are obvious pieces that are much better suited for that, and also how do you avoid cementing low-value care to just digitalize, so to say, something that is not creating value to patients? How do you think about that when you choose what to keep and what to not keep? Have you any reflections on this?
Yeah, well, I think that the COVID forces us to do something we don't want to do. On the other hand, the new form of communication is very practical, but it depends on the permission and the discussion with the patient. You need to check whether he or she feels comfortable with it. If not, then you shouldn't do it. And you shouldn't forget that just sometimes shaking a hand in the era that we could shake hands is for a physician already important. He can feel whether it's the cold hand or not the cold hand. Even the handshake is important. So we shouldn't do everything digitally. No. But on the other hand, you can measure many things remotely which are of importance in your consultation, but no matter whether it's virtual. So I think, and certainly in diabetes, but other diseases as well, pulmonary function testing can also be done at home, blood pressure measurement, weights, etc. So I think we can do much more, also with pregnant women and urine testing and blood pressures, etc.
Yeah, we also built an, I do my programming myself in the weekends and so on. Yeah, still. And so I built an algorithm to identify the risk patients. Very carefully, where you should not let them too early, too remote or too far remote, and keep in close contact. And that risk profile is continuously monitoring those that you don't miss out. And it's also identifying patients where you could do remote care and should persuade perhaps the care provider to say, is this possible? Can you arrange with the patient that it could be done? Because otherwise they also move back to old care.
That's a great example, Christina.
Thank you so much, thank you, Anne-Marie, for this, and also Henk and Jan. And I think it's time to welcome back Peter to join again. After having heard the substantial progress towards high-value care made by the institutions that we have heard here presented, why don't we do the poll again to hear from you in the audience of any changes that you see in the challenges to transform to high-value care? Or do you still rank the challenges in the same order? So please start voting and do vote again, and let us know if you still have the same challenge as your number one, or if you in any way have changed your mind. And that will be still around the first part of health outcomes and how to define them, and the interoperability, the informatics interoperability that we heard is a big challenge that we have discussed somewhat now and heard from Peter DeBay about how they started and moved into the next steps. Is this still the number one challenge? And also, of course, then moving into payment models, and as the last third part, culture and the commitment. And I think, if I'm not mistaken, Anne-Marie, we already have the results, so please take it away.
We do, yes. They're still coming in here. I'm looking at the screen right now, and actually we do see a change. The payment models are now the top result. 34% of people think that is the main barrier, followed by the interoperable data platforms, then defining the health outcomes and commitment by leadership. So we can say that the number 1 and 2 position have switched. Payment models is the most important one now. What do you think about that, gentlemen?
Well, interesting, of course. For us as a university hospital, of course, payment is very important, but it's not a barrier. It might help, but it's not a barrier. Although when you extend the care to more integrated care with partners outside, then the payment model becomes a barrier, and it might help. So for me, it's not really what I would have expected.
Peter, how's that for you?
Honestly, it doesn't really surprise me that it switched around. I think you actually gave some good examples earlier about successful payment models. And I do think that it can be a barrier. I think from a hospital perspective, for example, quite often to achieve a certain improvement opportunity, quite often there's not a real business case for the hospital. And it has to do with the way that we are reimbursed for the care that we provide. So I'm not sure if we fully agree on this one. But it can definitely be a stimulus. I think if you have the right, so I agree on that one. So if you have the right payment model, it can definitely be an additional stimulus to achieve better outcomes.
But not a barrier. No.
But also from the payer side, it could also be a handle to allocate patients to the places where there is enough volume and knowledge available and infrastructure available to achieve better outcome and reduce the burden, let's say, also in cost for the insurance companies on the long term. And that is also not really developed well. That how do you reallocate the the patients to certain clinics where they do the best. You see it a bit in prostate cancer, but much of the time insurance companies face themselves with on the front page news in the newspapers and etc. So everyone is very shy and careful, but we have to move, we have to take the daring steps to get to the better.
Agreed.
If I may remark about the other three, the interoperable data platform. There is interoperable data platform, but for me it is interoperable data, which is already the most important thing to go for. The platform is something technical, but the interoperable data, and I think it's still a shame that in a country like, in a region like Europe, we still don't speak the same medical language. And there are good examples and good standards. I think that an organization like EIT Health and also the European Commission should much more focus on standardization and reinforce the use of standards. There are standards, they are good. We should start using them. And I think that no company information, EMR type of products should be able to launch their product without using standards.
We share data on a European level, and that is now expanding. Let's say that's not us, as it's a European program. And we started small with a very small and tiny data set. Yeah. And when that flows, it becomes tempting for all the contributors to add a field and an item gradually. So it gradually over years it expanded. And if you want to wait until you have the complete set, you can wait forever. Yep. But think big, start small, and do it.
Very much agree with that. But also very much agree with the importance of more standardization in the data. Yeah, definitely.
And also maybe to conclude this part, the least favorite, to say so, the least thing thought of as a barrier was the commitment of leadership. I think that's a good thing, that many people think that's not really an issue here. Would you agree?
Although for the management, the COVID period is, especially for university hospitals, that is a big issue. It gives financial losses, and the attention is going to one item and not to the future, because this is still the future. We are working on it as three pioneer organizations, but it's still the future. Yeah. And it withdraws the attention from the right future things, the innovative things.
And let's switch it back to Christina for now, because you're going to have a panel discussion and go into more depth about this. And of course, the same thing goes. If you have a question, you can absolutely fill that in and we'll monitor it for you. Let's switch back to Christina.
Thank you so much, Anne-Marie. And it's exciting to listen to you. And when we were talking about the reward systems, and Jan, you were mentioning the commitment from leadership. How do you see that we still have a lot of models being based on being reimbursed for what we do more than what we achieve? Isn't that a hinder in this direction? Because it might be difficult for leadership to commit if the payments are not related to the outcomes achieved. What would your reflection on that be?
Well, that's a very complex question. It depends on the disease we're talking about. I think that Henk elegantly stated that when you have a certain minimum volume of patients, then you can go into that direction. The complex care, as in a university hospital, is characterized by small amounts of patients, and that makes it more complex. I think that when you, for instance, compare breast cancer in a general hospital or breast cancer in a university hospital, is quite different. So we need to prove that it is different, and we need to prove that our results are equal to general hospitals. But if the patients are different, then it's more complex. So I don't think you can say in general that this is an issue. That means you need to compare university hospitals with a certain characterization of a patient population to another hospital similar, and that is in the Netherlands, but also outside of the Netherlands. And I think that's a very nice example of Santiago, that they have similar hospitals working closely together, and they can compare to each other. That makes it more easy. But still, you are comparing smaller groups, and then it's complex to be paid on just outcome.
But the outcome of Santiago might be, even in the future, if I may guess, if you compare, that they will quickly come to a conclusion to bring all patients of a certain group to one location, to even go to the next level. And perhaps we also have a kind of the history of the established 190 hospitals in the Netherlands, where if we could redesign this from scratch, we would have perhaps 30 big acute locations and perhaps 40 or 30 chronic locations instead of so many very complex hospitals with a mix of structure of chronic and acute care and different levels. So this is a very difficult business case to handle financially, but also to make contract with the insurance companies because it's so widespread. You never get a real focus on this.
Yeah, maybe to briefly respond to that, I think this is a very relevant point, and I think the volume-quality relationship, it's been studied quite a lot, and I think especially for highly complex interventions, there's a lot of evidence that when you do a certain procedure more often, you can deliver better outcomes. I think in the field of chronic care, and this is obviously also your expertise, I think this thinking is newly evolving, and I'm sometimes wondering, is this about having a physical location where you have high volume, or maybe it's much more about being able to manage a larger population of patients, also virtually, bringing the data together, learn from this data, and improve the care for the individual patient. So it's not necessarily, I think, about physical relocation, but maybe more about virtual relocation, and sort of, I think we're having a lot of these kind of discussions right now, also within our Santiago group, and I'm looking for more evidence of where is skill important, where does it really help you to deliver better outcomes, and it feels to me that this is quite relatively early stage, but I think we're learning sort of quite a lot actually in these interesting times, also in times of COVID, because we've been pushed towards more digital care.
My guess is you will reach better care by aligning hospitals, but at the end of the day, the teams want to more drink coffee together with the same focus and the same kind of game they want to play on achieving better outcomes. And doing this all remote, it also has to do with a kind of culture, and also facilities is an important factor in place. You can, most obviously you see it in the acute care processes like prostate cancer, operation procedures, lung transplants, etc. There it's a no-brainer to do it on one location. While chronic care, it doesn't change that quickly, but if you don't act now and not act next year, you will gradually get into the complication range.
I think there's something in between. So work, collaborate virtually and come together now and then to have that network. I think that for instance, the ERNs, the European Reference Networks for Rare Diseases, is a very good example. If we can achieve their collaboration virtually with the same data set, and we can work together with federated data, then you can achieve a lot of things together. And then, of course, you need to come together past COVID again in network meetings, but you can do the work on your own location, making it for patients easier to visit the hospital.
Yeah, because that's key, right? It's sort of what do the patients want? Obviously, are they willing to travel for a regular checkup? Are they willing to travel for a complex intervention? I mean, these are obviously very different decisions, and it also is different for each individual patient.
If you drive more than 2 hours, you're out of the country.
So we have the advantage, obviously, living in a very small country. But I also lived in the United States for quite a long time. I lived a little bit in Australia. I think some of the viewers today might live in countries that have very different travel times.
Of course.
And than we have. So we should be, so I would agree with you that we should be able to do this much faster perhaps than others, because the travel distances are so short. But yeah, but even we see that some patients are not willing to travel, right? Or at least,
Yeah, and you mentioned that you thought it's a pity that Europe doesn't have interoperable data, as you said, not platform necessarily, but data. And what do you, the three of you, see as needed to make this, what you just discussed, possible from the informatics perspective? What could Europe do?
Well, I think that for instance, the SNOMED vocabulary, that it's a standard for medical terms and all kinds of procedures. I think it's still not published in French and in German and of course not in Lithuanian and in other kinds of languages. So if we start with agreeing that, for instance, SNOMED is the medical language of use in documentation of all things happening in medicine, then you should say, okay, then we go to translate it from now, and at the end of the year, all 26 European languages are to be used in SNOMED, for instance. But then you have the other also the laboratory standards and the exchange standards and etc. So I think it's already there. It's just saying we agree, and now it's law. We can make a privacy law. It took some time, but okay. And now let's have some standards and use them, reinforce them.
Yeah, I would like to echo what you say. So I think really focusing on good information standards and enforcing them, I think, is really one of the core things that we need to do in order to make it much more easy to collaborate, even within countries, but also across borders. I also think that at the same time we need to work on techniques to make it easier for clinicians to to register data, right? And I think there's so much talk about bureaucracy, just having to spend way too much time on a computer to enter information. And I think there's now more and more techniques that make this a lot easier. But also there, standardization would help, because then you can actually find solutions that already sort of, put the data in a particular standard, and that's still not there. So I agree. And yeah, so I think, but you need to do both, right? We need to come up with solutions that work in the clinical setting for the clinicians and for the nurses.
Real workflow support,
and give them a feedback loop, right? And I think this is where you, Henk, and your organization have been very good at, right? Is kind of, have this feedback loop to the professionals so that they actually also have a reason to enter it in the right way, because you can see the results.
It's your research database, it's your clinical database, your performance database. So if you do the data entry at the front end right and only once, then it should be, then it's done.
Yeah.
There are no further request form to insurance companies for materials. We have already prescribed a certain pump, and that has a certain type of disposables. So it's already done. So it's only that is dealt with in the background.
It's a smooth workflow, right? That works, And I see this in many different, also like what I see happening is that people start measuring PROMs, right? Patient-reported outcomes. And so they send questionnaires to patients. And then they never show the results to anyone, right? They don't show it to the patient, they don't show it to the clinician. And then obviously they see, well, it's actually, we get to quite low response rates, 30%, 40%. Of course you get to very low response rates because nobody is really interested in it, right? So you need to set it up in a way that it really helps the clinical process and the conversation.
And also it helps if you bring the data to patients. When we started reporting back immediately, this went crazy. In a year, we had 80% patients using the system.
We had the same experience. Absolutely. Yeah, it only works when you use it in the consultation room to improve the consultation.
And then the patients will ask. Then the patients will ask you, why are my data not there?
And it gives also both the physician and the nurse specialist and the patient a tool to prepare the consultation and to make it more efficient, because you don't need to speak about the things you think are right, and you want to speak about the things you think are cumbersome or a problem.
But I think this is the part that requires training, because this doesn't come naturally. This is not how traditionally these conversations were structured. This is not how most professionals are trained. So here's where I really like your earlier point about the importance of education, and put it in medical training. Sort of the way of working in a much more data-driven way, using this information in the conversation. I think this is where that the success will really depend on.
The awareness in the students becoming a doctor, a physician, is very important. That it is not about the right diagnosis and applying the right procedure, but also aiming at the right outcome. And
exactly.
That is something which is relatively new.
And to see the patient as a holistic center, instead of that just you look at the organ you're supposed to be the specialist in. That means that when you are discussing the patient-reported outcome, it might be as a surgeon that you need to come to the conclusion that the patient has a depression. And then not say, well, that's not my field of expertise. No, then you should, as a team, take care that the depression is taken care of. Yeah. And that needs certainly education. Yeah. Yeah.
Yeah. Thank you so much for that. Sorry, Peter, any last comment? Sorry.
No, I thought this was just very important point. I mean, I think you cannot measure outcomes, patient outcomes from a procedure perspective or from a specialty perspective. You have to do it from a patient perspective, and therefore it's multidisciplinary, right? So it's the result of the entire effort, the entire team, the entire care pathway. And I think this changes quite a lot, because traditionally, especially in hospitals, we're very much organized around specialty by specialty by specialty, and this is not what a patient experiences, and this is not what determines the outcomes in the end. So that was just a reflection on what Jan just said.
Yeah, thank you so much. And I think that is an excellent ending of discussing this cultural perspective that we are talking about now, the third part in transforming towards high value care. And actually there is work to do to get this into the undergraduate medical education for all healthcare professionals to really move that needle is very much needed. So thanks for all those insights, and let's take a further step and look into EIT Health. As we have heard from EIT Health's CEO of EIT Health, Jan-Philipp Beck, in the introduction, societal impact towards better health and stronger health systems and a competitive health economy. Societal impact is central to EIT Health. And societal impact builds upon the cornerstones of ethical, legal, and social principles, making sure that developments within the health sector actively involve the people they are intended to serve, and on moving towards high-value care. And to support this transformation, we heard that EIT Health has established a high-value care forum. And the question now would be, what would you see as the most important item for EIT Health? And let's have a look at our second poll today. And please start voting now. In order to support the transformation of healthcare to high-value care, what would you vote from the audience as the most important item for EIT Health to focus on or consider as a next step to continue this support long-term and the transformation journey? Is it about co-creation, being able to initiate co-creation with hands-on learning opportunities to refine projects in Europe? Or is it towards more of education with face-to-face and online training opportunities? So more focused on education than maybe hands-on learning. Sharing of best practices, we already heard through Library of Cases, and of course international conferences in new formats, bringing together good examples, or providing guidelines and toolkits to improve implementation. If there is anything else that comes to your mind, which is not in this poll, as important for EIT Health and then is not covered here, please let EIT Health know, and you can then type your suggestion or ideas in the question section, and Anne-Marie will keep an eye out for this and make sure that it gets into, if not the discussion here, at least the reflections after this session. And I'm not sure, Anne-Marie, if we have any results yet, or if they are. Yes, I see something on my screen here. Please.
There's a lot of movement in them. At first they were flipping around quite a lot, but I think we can say that it's established that co-creation with hands-on learning opportunities to refine projects is the one with the most votes. And then followed by producing guidelines and toolkits to support implementation. So they have about 37% and 28% of the votes. So co-creation, that's our top result. Any thoughts on that, gentlemen?
Yes, I think that the differences are not that big between the four possibilities. I think that the conclusion is that the real implementation work, whether you call it hands-on or guidelines or face-to-face meetings, the real implementation work, I think that's educating that kind of stuff is very important for what we want to achieve. Yeah.
Big surprises to you, Peter, or
No,
Visse?
not really. I think we have also some learnings where we created a new location on another space and took over all patients and the care team in a diabetes surrounding of IT and facilities. And in 1.5 years, they achieved the same outcome as it was the learning of the team, the facilities, and if you can call that co-creation or not, but let's say the great work is if the closer you work together, the better you achieve your targets and the learnings.
Right. Yeah, and I think what you see from the results is that really people need practical examples, right? I think that's what you said as well, Jan. And so I was a little bit surprised that the sharing of best practices is number 4 on this list, because I thought that there would be a lot of interest in that as well, and especially in learning internationally, because I think that could be the role of EIT as well, is to make sure that we share best practices and learn from each other across borders. But you could also say that is also in the first one. So I think it's
the difference are not that big. Yeah. So if I may try to answer the question in a different way, when you say what can EIT Health do, then I think that's for me 3 words: it's stimulate, educate, and it's integrate. And stimulate means that you already do so by giving value-based healthcare a good podium. Educate is a broad education. There's really a need for education on this topic throughout Europe, in every country. And integrate is, I think there's happening a lot in all kinds of European projects, not only EIT, but also IMI and H2020, etc. I think we should try to combine all these efforts and not only focusing at what I call the information standards, but also at something which is quite different. Outcome is very much related to the quality of care, but is also very much related to the socio-economic situation of an individual patient. And I would try to make a plea for more attention to the socio-economic situation of patients. It's very important. How are we going to handle this? Because the differences are so big in Europe and becoming more and more bigger, the difference between have and have not, etc. I think at those circumstances and situations are very much related to outcome. And we need to find a solution or at least an approach for that.
I think that's a clear thing to mention here and a good message as well. I'll switch it back to you, Christina.
Thank you so much again, Anne-Marie. And I would like to understand from you there's so much you have covered today here, and also there is a huge opportunity, obviously, in what has been discussed for EIT Health High Value Care Forum to support and make these islands become continents over time, very practical, as you have all pointed at. Before we move towards closing this session, I would ask for the 3 of you, in which order you would like to say, what if for someone who is going to move into this space and consider starting, what would be your single most important advice to consider? If you have to choose one piece that you say, start and focus, do this, what is important to you?
Who would like to start on that one?
I think one of the most important, in my experience, is that focus, choose one thing to do best, and then be daring enough to do it. Just do it.
Go for it.
Go for it. We put my house in mortgage to the bank to get my first loan. And then you get commitment of your family, you get commitment of the team. That is really just do it, drive for it.
Take a little risk.
Yeah.
Anything to add to that?
Well, I don't think that the advice would be to put your house on a mortgage and then start using it. But anyway, that's real commitment. Yeah. But I think it's agreed, and you said think big and start small. Of course, start with a disease team, which are enthusiastic and want to be an ambassador, and then grow from there. And indeed, just do it and improve. Small steps, but improve. Continuous improvement.
Some closing things to add?
Yeah, from my perspective, I think this is all about define outcomes together with patients, but use the standards that are already there. There's already so much work done, so don't reinvent the wheel. Just use what's already out there. Start measuring those outcomes and start discussing them in your team, because I think this will start to change the mindset and in the end the culture of your organization to be much more focused on patient value. And that's what this is all about, I think.
Very clear. Christina, shall we move on to some Q&As if you're okay with that?
Yes, of course.
Here we go. Some of them have been coming in, and one that's very popular, gets a lot of votes. So let's start with that one, is how can we use our EIT Health network to speed up and adopt this high-value care approach faster among the many partners? Do you have any ideas for that? How can we use the network in a better way?
No,
difficult questions. Go
I
ahead.
already tried to answer it by saying, as a EIT, focus, work on education, because the majority of items is not trained during your medical or nursing training, all these kinds of new things, and integrate everything which is happening in Europe. Mm-hmm. I think that's the most important advice to the EIT Health.
Anything to add?
I would suggest also to link up with existing conference platforms so that it gets known in the wider public. It speeds up the process, and it may adhere more patients to the EIT efforts.
Make it known is what
Make
you're
it
saying.
known. Yeah.
Maybe a marketing campaign?
Yeah.
Could be. All right. Let's move on to the next question. Let's see. Yesterday, 2 days ago actually, we were talking about artificial intelligence, and this is a question about that as well. Is AI helping a better outcome? How do you use it in your setting? And she is referring to one of the presentations that we've heard a few days ago, but let's just focus on AI in general. Is there a role for this in patient outcomes?
Yeah, from my perspective, absolutely yes, but it's still very early stage, right? So, for example, we started on our COVID improvement cycle, actually, that I talked about earlier, started building algorithms together with an AI company to predict the disease progression for our COVID patients. And I think these kind of, products, information products, we're only learning now how to use it in a clinical setting, but I'm absolutely sure that will take a role in future decision making, again together with patients. So I do think that it needs to be transparent. Mm-hmm. It shouldn't be a closed box. It should be an open box. It needs to be clear what it does recommend based on what kind of information. But then it will definitely be. Will be something that will be part of the way that you provide care in the future, in the near years. Actually, I think it will go quite quickly in some areas.
Yes, that is an exciting field. That things are happening.
It's very interesting, and we can't do without it. Mm-hmm. We use it for all the incoming data to see where there is change to the wrong side and where we have to look at. You cannot do that manually in so much data which are coming in every day. So there must be a kind of smart filtering and sorting and algorithm linked to different items in the database. So we have a special cloud team watching it, just like Eurocontrol for the planes. Mm-hmm. They take care and guide the planes safely towards where the airports takes over the more severe tasks like landing and etc. So algorithms play definitely a role there, and also finding, let's say, the different patient patterns or streams to say which patient group is best fits in a cloud care solution and which they are in more deprived circumstances should have more a warm handshake.
So you're not saying we should be using it, you already have to be using it. It's a must. Okay. Yeah. And with that, let's move to our final question. And I want to focus a little bit on the human element. I think it was a good question that came in. Many patients find the medical world very intimidating and might not formulate their preferred outcome easily. How can you ensure that they actually do? Dr. Hasselset.
Well, the groups, the disease teams who are most successful are working with nurse specialists. That means in our situation that they send out the questionnaires, they receive it back early before the consultation, discuss it in the team, what the consequences are, and then they discuss the same results with the individual patients. They have a more holistic view, they spend more time with the patient, and together with the patient they select the items which are very important to discuss with the specialist. For instance, in Turner syndrome, we had the use of 8 rooms with 8 doctors, 8 physicians, and they went in on all those rooms with the same kind of time, small amount of time, and now they select the ones which are important to them based on clinical and patient-reported outcome. So it's
Right, so
extremely important.
Actually taking them by the hand to make sure that they do it in the right way.
Yeah.
Nurse specialists are crucial in this kind of teams.
Very important
Yeah,
role.
I think this is a great answer. So I think the role of nurses is super important in this. And secondly, I think also peer support. So have patients, get together and have discussions together, and that really works well. In one of our hospitals, we've set up a whole system, sort of a buddy system, where people team up, patients team up. And then I think that gives them much more confidence to share their own experiences, and they're not alone, and together they get to the right, or to the most important outcomes. Yeah.
2 great ideas. And with that, we have to conclude our question and answer round. So I'm going to hand it back to you, Christina.
Thank you so much. And thank you very much to Peter, Henk, and Jan for sharing your vast experience. And thank you everyone in the audience for your active participation and clearly guiding, also giving insights to EIT Health and the High Value Care Forum on the importance of co-creation and creating these ecosystems with all stakeholders to refine projects and really move the needle from islands to become continents. Over the last 90 minutes, the discussion has covered health outcomes essential to achieve high-value care with transparency for benchmarking, learning communities, and shared decision-making as central themes, but also the importance of setting the reward systems internally and externally towards health outcomes. Internal commitment and long-term support are essential to create the ecosystem culture with all stakeholders present. So finally, as also noted, no true societal impact towards better health, stronger health systems, and a competitive health economy will be possible without making sure that developments within the health sector early and actively involve the people they are intended to serve. So with this, I would like to hand back to you, Anne-Marie, and you will prepare us for this afternoon, as there is more to follow on this theme, if I'm not mistaken. So over to you.
With pleasure. Thank you so much to everyone contributing to our conversation. And of course, thank you so much, Christina, for moderating this discussion. It was clear to me that the true impact of healthcare relies on meeting the patient needs that truly change the patient outcomes and their quality of life. Now, if you want to rewatch this session or share it with someone, you can. It has been recorded. Let's take a look at some of the tweets that have been coming in our hashtag. There's 2 that we've highlighted for you. Well, the first one is in English, the second one is in Dutch, and that is a shout out to Pieter de Bij, who was here on stage by the Santiago Hospital Group, just saying he's speaking here today. So thank you all for sharing that as well. After a lunch and a networking break, the rest of today's session will focus on showcasing a selection of the EIT Health projects that advocate the provision of high-value care. And these projects, they are, and you can pick from them, using the webpage. They are an opportunity to showcase specific projects, and of course also in these sessions there's plenty of room for your questions, so engage in the conversation. The projects that you can choose from, and you can watch and look at the website for some more information on them. The first one is Combating Childhood Obesity. The second one is Integrated Personalized Diabetes Management. The third, Are All Outcomes Equal? We only do that one in the first round. And last but not least, Delivering Outcomes That Matter by Exploro. We have 3 rounds, and there will be bite-sized presentations. They will be repeated 3 times in succession, just to make sure that you don't have to miss out on any of them. The first round will start at 1:30, the second round at 2 o'clock, and the last and final round at 2:30. I would say enjoy your lunch, have fun meeting our innovators, and have a lovely rest of your afternoon. Goodbye.